So for the beginning, we start with the full volume data set, and now again I show you the different cropping options. That was a full volume TOE data set. First I cropped from the front, and now I cropped it from the lateral, turned it around, and it's also possible to reset cropping and go and crop half crop in the transverse plane and then look at inside the different cardiac chambers. So it's always nice if you are able to acquire nice and good full volume data sets. And what we work with is the so-called 4-valve view with TOE. So how to obtain a good 4-valve view by TOE? Let's start with the mid-esophageal 4-chamber view. We switched on full volume. What is displayed on the screen is an half-cropped, auto-cropped full volume data set. So this is only just a half of the data set. And then we will increase a little bit the lateral size, reset the crop, and tilt anteriorly a little bit. And then with the help of Z rotation, when the axis of the rotation is perpendicular to the screen plane, we just anatomically rotate the data set, and this is how it will appear, the so-called 4-valve view of the heart. And then we can use anatomical orientation, and we will practice it, so please remember this one. It is very important when you use 3D, because if you don't have many landmark points in your volume, because you reduce the size of the volume to increase resolution, you will get lost in space. If you don't have landmark points or have only a few you will get lost. But if you know how to produce anatomical orientation, you will get where you are, okay? So this is, what is that? You can see this is acquired at 6-state bicomissural view. You can see the half-crop full volume data set. And how to produce anatomical orientation, I will show you in a few slides. So acquire this one, and then reset cropping, display the entire volume. If you are ready with that, you will have to grab this bottom line and rotate it upward, so to change the direction by 180 degrees. And then now this bottom line will appear on the top, and you should align it with the degree where you acquired your loop. So I rotate it towards 60 degrees, and when you have got it, just make a final 180 degrees rotation. So this is right now the anatomical orientation, and even if the data set is smaller, you will be able to know where is anterior, which is always on the top, posterior, which is always on the bottom, this is lateral, and this is medial, okay? So you have to learn it and use it in the daily routine. So this is our 4-valve view in anatomical orientation. You can see that the great arteries like aortic and pulmonary valves are in front of the atrioventricular valves. So this is the so-called base of the heart, and the pulmonary valve is always front and left of the aortic valve. So this is how it looks like. I'm sorry for displaying in the presentation with stitches, but it was the aortic valve and front and on the left, and in a more superior position we can see the pulmonary valve. The aortomitral continuity is very important. We do know that the posterior wall of the aortic root has got a continuity with the mitral annulus, anterior annulus, and the anterior mitral leaflet. So here you can see the non-coronary and the left coronary cusps and their posterior wall, which is in direct communication with the mitral annulus and the base of the anterior mitral leaflet, which is prolapsing in that case. So this is a direct communication continuity, and it is easily recognized by 3D. We also do know that where are the commissures? The posteromedial commissure is always close to the interatrial septum, and the anterolateral commissure is beneath the orifice of the left atrial appendage. So with slight tilting of the data set, we can separately analyze and assess the different commissures, which might be important in case of rheumatic valve disease or with regurgitant lesions. Right now you can see I tilted my data set toward the anterolateral commissure, and that's why some portion of the left atrial appendage appeared on the screen. But we can also focus on the orifice of the left atrial appendage. This is a nice appendage, and we easily recognize that this appendage has got two lobes. So in case of structural intervention, when we would like to close the orifice, we should select a suitable device to close both lobes of the appendage. There are a lot of anatomical variations. On the left side, lateral to the orifice of the atrial appendage, there is the villus ridge, which separates this orifice from the entrance of the left upper pulmonary vein. But there is a very frequent anatomical variation that the left upper and the left lower enters the left atrium with a common trunk. So this is very often can be seen. On the right side, the most frequent anatomical variation is that we have supernumerary pulmonary veins, not just the right upper and the right lower, but some extra veins. If you look at this image, it is a half-cropped image from the front. So on the lateral side of the entrance of the pulmonary veins, you can see the superior caval vein and some portion of the right atrium. Now we tilted a little bit different direction to visualize our data set to visualize the coronary sinus, which is behind the left atrium, and the entrance is in the inferior portion of the right atrium. This is the en face view of the orifice of the coronary sinus. As far as I can see, in that case, there is no trapezium valve gathering the orifice. So the coronary sinus is visible always behind the left atrium. Let's have a look at the interatrial septum. We can look at the septum with the help of 3D from the left side or from the right side. The central portion is the fossa ovalis, and you can see. And this is the left side of the interatrial septum. This is en face view from the left atrium. It's quite featureless. We can't see many things. Just we see that the foramen ovale looks like a little bit thin structure, and there is a rim where the septum primum and the septum secundum in that case was not 100% merged. That's why sometimes under this rim a small pouch will appear, which is the pouch of the flap of the foramen ovale, and it might have significance in case of thromboembolic disorders when small thrombi can develop under this small pouch. The inferior portion of the interatrial septum, as I mentioned before, is close to the posteromedial commissure of the mitral valve. The central portion is the fossa ovalis. This is the opening of the fossa ovale, and in close proximity we see the non-coronary cuffs of the aorta, the transverse sinus in between the vessels, and the superior caval vein. So these are in close proximity, and these might be quite good orientation points in case of multiplanar reconstruction of the images. Behind, on the right side, there is the roof of the coronary sinus, and it's an important region in case of special forms of ASDs. Why is this en face view important? It is important because of the transeptal puncture. When we perform structural interventions, the interventional cardiologists have to cross the septum, and it does matter where he will cross the interatrial septum. So this is the position of the transeptal puncture is very important. For example, we should select a superior-posterior crossing point in case of mitral clip implantation. But if we would like to close the appendage, we would select a posterior-inferior point for the crossing. And during the intervention, when an echocardiographer will provide this en face view, it's easily recognized where the interventionalist tried to cross and is it a proper place for that intervention or not. The foramen ovale may be patent, and sometimes those muscular strand-like structures are attached and try to cover incompletely the opening of the fossa ovale, the flap of the fossa ovale, and that's why single or multiple orifices may develop. So this is how a patent for ovale would look like by echo. And sometimes when the overlap of the two septa, the primum and the secundum septa, looks like a strudel, we can detect a long channel which might be open on the right side or closed. And if it is open, of course, it has got a potential to embolization, and for example, an in-transit thrombus can pass through this patent ovale apertum and cause systematic embolization. Where are the septal defects? We know a lot of them. In the central portion, the ESD2, close to the AV valve, the ESD1, and this is the sinus venosus type, superior or inferior type of sinus venosus ESD, and the unroofed coronary sinus would enter into the left atrium like here. So those regions are marked on this 3D image, and of course not only from the left side but both from the right side we can use those typical positions of the different types of ESD. And now let's go into the right side and we look at the interatrial septal region from the right atrium. So this is a right aspect, and let's start with the inferior part, which is quite interesting because this is not that featureless, not that boring like the left side. We have a lot of important anatomical structures which can be visualized more or less by 3D echocardiography. From the right side, the foramen ovale has got this muscular ridge, and beneath this one there is the orifice or the coronary sinus, and this is the annular plane of the tricuspid valve. So this is where the AV node is in reality. Of course, those structures can be seen on 3D images if we cut the front plane. Eustachian valve or ridge, if it is a little bit enlarged, will separate the entrance of inferior caval orifice from the coronary sinus, and it is merged with medially with some portion of the interatrial septum, the inferior walls. So we can rotate a little bit the data set and you can see how much it separates the coronary sinus from the orifice of the vena cava inferior, and of course the fossa and the interatrial septum is more superior with this attachment on the middle portion. There are sometimes difficult anatomies. First, when the orifice of the coronary sinus is covered by a Thebesian valve and they can't introduce with the pacemaker lead, or if the Eustachian valve or ridge is quite prominent, that might cause problems during interventions. And sometimes there is a pouch beneath the Eustachian valve, which is called sinus of Keith, and pectinate muscles can encroach this region. So when they perform ablation techniques, the arrhythmologist may get into trouble in those anatomical variants. And this region is very important because this triangle is called the cavo-tricuspid isthmus. So be aware of the anatomical variants of sinus of Keith or the Eustachian valve. And this region is important because arrhythmologists will perform ablation lines on this region. For example, an AV nodal reentry tachycardia, the septal ablation line will be selected, which is very medial, close to the interatrial septum. But in case a common flutter, they would perform an isthmus ablation, and a lateral ablation line would be selected. And of course, if you use 3D guidance during the intervention, that might help the arrhythmologist to select the proper place. And now let's have a look at the superior part of the right atrium. And the most important anatomical structure is the crista terminalis, which will separate the smooth venous portion of the right atrium from the muscular trabeculated portion of the right atrial appendage. So this crista terminalis is a C-shaped structure originating from the superior vena cava and going parallel with the lateral wall of the right atrium. The right atrial appendage can be visualized if we half crop the posterior portion. So now we get back and look from the posterior aspect to the front. And here you can see this trabeculated right atrial appendage. And the most important anatomical structure is the sagittal bundle. Again, it is does matter important for the arrhythmologist because some special forms of arrhythmia can originate from there. Very often we can see muscle bands connecting different portions of the right atrial wall, and you can see that trabecular ending of this muscular band. Many people are referred for surgical intervention to remove those structures, but those are anatomical variants, so they are really harmless. So you don't have to do anything. And very often we see strange structures in the right atrium. For example, let's discuss it. This is a right atrial 3D zoomed image, and you can see moving something in the right atrium. Do you have any idea what is that structure moving in the right atrium? Any idea from the audience? No? No? It's a thrombus. And how was it defined? We just see it first time. So it's a very large thrombus moving in the right atrium. The length was almost 15 centimeters and the width was 1 centimeter. So it looks like my thumb. And how could we define what's that? Is that a tumor or something like that? With three-dimensional echocardiography, we made the multipreanal reconstruction, and with the help of this one, we could detect that the attachment point of this moving mass is just on the lateral wall of the right atrium where the pacemaker lead contacts the wall. And there is always an endothelial injury on the wall, which is a risk factor for thrombus formation. So our idea was that it might be a thrombus, and because of the big size, it should be removed surgically. So we offered surgical operation for the patient, who was much more clever than we were, and he rejected. He refused to undergo the surgery. So we just administered oral anticoagulant therapy for half a year, and this structure 100% completely disappeared from the right atrium. So we kept the patient on this anticoagulation. What about the ventricles? Again, from the base of the heart, the right ventricle looks like a crescent-like structure in front of the great arteries and the left ventricles. So this is how it looks like on the four-valve view. And in congenital heart disease, sometimes it's not that easy to define which is left ventricle, which is right ventricle. So we have some anatomical help because we do know that the septal leaflet attachment of the right ventricle is positioned deeper, and the septal leaflet, which will characterize the right ventricle, always have direct cords which are inserted on the wall directly without papillary muscle in between. And the trabeculation is more coarse in the right ventricle, and there are more papillary muscles. So with help of a good 3D loop, all those characteristics can be defined, and in congenital heart disease helps us to recognize which is left, which is right. This movie moves so strange. So let's look at the interventricular septum, and we always do that first from the right side. So we crop the front of the heart and look at the IVS from the frontal plane. And we can see that the right ventricle can be divided into an inlet, an apical, and an outlet portion. And in between the inlet and outlet portion, the crista supraventricularis is an anatomical landmark point. And one branch of this crista is the trabecula septomarginalis, which is also visible. And a branch of this trabecula septomarginalis would be the moderator band, which is also can be seen with 2D echo. The different septal defects in the ventricles can be localized on different regions, so we go through all of them. The most important or most common form is the perimembranous inlet type VSD, which is beneath the tricuspid septal leaflet, and very often we can see an aneurysmal redundancy of the leaflet or the wall or the fibrous septum, which can completely cover this VSD. So let's look at the frontal view of the inlet type VSD. With slight rotation we can easily better recognize, and this is from the posterior aspect, the same perimembranous inlet type VSD. The second one is the outlet type. Let's get back here, which is positioned here. And this outlet type VSD is beneath the aortic valve, and that's why the support of the attachment of the right coronary cusp is weakened, and it might cause very often aortic regurgitation. The muscular types of VSD might be singular or multiplex. Very often the IVS may look like a cheese with a lot of holes. This is a multiple form of muscular VSD, and one single hole on the left side might have several openings on the right, so it's like a tunnel type VSD. This is the subarterial VSD, which again can also cause aortic regurgitation. And the most posterior localization is the Gerbode type VSD, which will result in an left ventricular to right atrial shunting. It can be congenital. This is a nice type of a Gerbode type VSD with color, and another with again cropping and multiplanar reconstruction. We can see from the left this Gerbode type VSD, and with the rotation from the right side. Around this VSD you can see some weird, strange, irregular mass, which was vegetation. So this Gerbode type might be iatrogenic or due to infective endocarditis acquired Gerbode VSD. So this is just the basics. Thank you for your attention. Now we're going to have a coffee break to digest a little bit and continue.